Our next speaker I'd like to introduce. Dr. Ali Freimund is a medical oncologist and PhD student working at Peter MacCallum in Melbourne. Following on from the theme of ovarian cancer, Ali will present our next session, The Future of Ovarian Cancer is Targeted Therapies, the Importance of OASIS, and Introducing the PRECISE trial. Dr. Freimund is the lead investigator for PRECISE, and please welcome her to the stage.
Thank you, Karen, and thank you, ANZGOG, for inviting me to speak. I'd like to all welcome you and thank you for your attendance, and a special hello to all of those live streaming in from wherever you may be. As introduced, my name is Ali Freimund, and I'm a medical oncologist currently working at the Peter MacCallum Cancer Institute in Melbourne. I am also a PhD student, so after all of these years, I've become a student again, which is a challenge and also quite a reward. So I'm just entering my third year of my PhD, and today I'm going to talk to you a little bit about ovarian cancer, which is my area of sub-interest, and talk to you also a little bit about the PRECISE study, which has been recently funded and supported by ANZGOG and OASIS, and a study that we're hoping to open around Australia in the next 2 months. So hopefully I can get this clicker to work. We've had some issues this weekend, but it's looking perfect. So what do we know about ovarian cancer? And I just thought I'd start by asking for a show of hands so I could get to know the audience a little bit better. But who here in the audience knows someone who's had ovarian cancer or has been personally affected by ovarian cancer? Great, wow. Great and not so great, I should say. I guess for those live streaming, that was the majority of the room, and I guess it's a really important point for us to be aware of ovarian cancer, and wonderful to see so many people who've been personally or somehow connected with ovarian cancer to be here today learning more about what we're doing to improve things. So this is a challenging slide to always put up, but I think it's a very important slide because if we don't discuss the challenges, how can we improve upon them? And what we know with ovarian cancer is that through excellent surgery, we hope to cure patients of ovarian cancer. But the unfortunate reality is that many patients do recur. And when they do recur, we know that the survival rates still have quite a ways to be improved. This is a graph showing that after recurrence, patients at 5 years probably have a 13% survival rate, which is actually very, very low. And this is a little bit of historical data, and certainly I don't think this reflects a current patient coming through a diagnosis and cancer treatment. But again, I highlight this so when we come to the end of this presentation, hopefully our outlook will be looking a bit brighter. So why has this been such a difficult disease to treat? And I guess the background is really that we thought ovarian cancer was one disease, as Karen alluded to. We thought anything that occurred around the ovarian structures was an ovarian cancer, and we treated all of these diseases as one. But what we now know is that there are 4 very different types of ovarian cancers that look different under the microscope, that behave differently when we treat them with chemotherapies. And we know that they actually have different responses to treatments and really have different unique molecular features that we can study in the lab. Highlighted here in red is high-grade serous ovarian cancer, which potentially many of you have been involved in someone's care with high-grade serous cancer. And this is the focus of my research because it's a very common, actually the most common type of ovarian cancer, and it's a very challenging cancer to treat in the clinic. So as alluded, we're learning more about ovarian cancer, and what we see here is a complex, what we call a pie chart. And if you look here on the upper right-hand corner, this highlighted section in red illustrates patients with high-grade serous ovarian cancer that have what we call a Braca mutation. Now, for the sake of time, I won't ask for another show of hands, but I suspect if I asked how many of you knew something about a Braca mutation, that would be the majority of you, which is fantastic. And this graph, I guess, I used to illustrate how much understanding we've developed about high-grade serous cancer. And particularly, again, my area of research in this red box is patients with Braca mutations that traditionally should respond very well to treatment and can also be treated with targeted therapies, not just chemotherapies that can treat cancer cells globally, but therapies that can really hone in on these Braca mutated cancer cells and work to improve outcomes specifically for patients. So this is a schema that I love showing because it actually shows how the management of ovarian cancer has changed significantly since I started treating ovarian cancers. And just to walk you through the top of that, as we are aware, patients often present with advanced disease because of symptoms. They undergo surgery, followed by chemotherapy, and traditionally we would observe patients very closely, acknowledging that there was a chance that the ovarian cancer could come back. And should the disease become active again, we would discuss surgery if it was felt to be suitable, but in the majority of cases, we would discuss more chemotherapy. More recently, for patients with Braca mutations, we've identified a targeted drug called PARP inhibitors, which is a class of drugs that we know can be very effective in maintaining cancer control in patients with Braca mutations. We now have access to this drug for patients who have a Braca mutation and who've responded to second-line chemotherapy, and this is funded through the PBS here in Australia. Most recently, though, and very exciting, is some data that's come out from a study called SOLO-1. And what that data has shown is that if we use these PARP inhibitor drugs earlier in the treatment setting of patients, we actually see better control in the maintenance setting. So we see almost a year and a half of prolonged control of ovarian cancer if we use it actually after the first line of chemotherapy, when we've already obtained a response from chemotherapy in patients. The challenge is this drug is not yet PBS funded, and as an organization and as a group, I believe we'll all be fighting very strongly to get access to this drug for patients. But the good news is we can access it now currently compassionately, case by case for patients. But the challenge is, even with these new targeted drugs, cancer is still very clever, and it can develop ways to become resistant. We say in this slide inevitable, but I'm hoping the next time I present this, I can change the wording of that to say that not always the case, that potentially we can really maintain ovarian cancer control better than we currently can. But this slide is a complex one, and it actually reflects some of the research done in the lab where I'm doing my PhD. Several years ago before I joined the lab. And I'll walk you through it, but the schema is just there to refer back to. But what this research did was it looked at doing complex genome sequencing, so looking at the DNA structure of patients with high-grade serous ovarian cancer, and looking at samples when they were first diagnosed with cancer, and samples after they'd been treated with chemotherapy, and samples at the time when resistance developed. And these studies were looking to try to understand why this happened, how we could target these mutations or these resistance mechanisms as we refer to them, and how we could improve treatments and outcomes. Now, highlighted in the top box are the most common two types of resistance mechanisms. On the left-hand side, you'll see what's called a Braca reversion mutation, which is really just another DNA abnormality that can occur in the Braca gene that's already affected. And what that means is if you develop another Braca mutation in the mutated gene, treatments that targeted that Braca abnormality may no longer work. And so we have to be one step ahead of this potential for resistance developing. On the right-hand box is another complex mechanism of resistance, but what we believe can occur in up to 30% of patients who've had chemotherapy for recurrent disease. And this is referred to as an ABCB1 fusion. Again, in science, none of our names are particularly attractive, but that one's not so bad. But what an ABCB1 fusion means is that a DNA abnormality can occur in the cancer. And there's what we call a translocation, or a move of some of the DNA coding elements. And that actually drives what we think of as a drug pump. So what that means simply is that if you have a treatment going into your body to treat your cancer cells, and it develops this drug pump, the cancer cell can push the drug outside of our control, and potentially still grow and become resistant despite continuing that treatment. So it's very important that we identify patients who have these pumps so that we can try to target them with drugs that potentially don't get pushed out of these pumps if this fusion abnormality occurs. And so why is that relevant? Well, in red are all of the chemotherapies we believe that are actively pumped through this ABCB1 fusion should you develop a fusion abnormality. And that's quite a lot of the drugs that we use in ovarian cancer treatment. Paclitaxel, Calyx, etoposide, and some of the PARP inhibitors, and in fact the one PBS-funded PARP inhibitor we currently have called olaparib. So the challenge is if you have a fusion, we are concerned that these drugs may no longer work and may explain why patients have become resistant. So if we could find a drug that worked in this setting, that wasn't pushed out through this pump, we may potentially be onto something really good for patients. And for me. So now this is a complex slide, but we'll run through this together. But that translational background, or that lab research I've just been referring to, really led to the generation of what we call the PRECISE study. And the PRECISE study, again, is a terrible long name, but we've abbreviated it, and it basically stands for the use of a new PARP inhibitor called pamiparib in patients who've developed this drug pump, who don't have a Braca reversion, and who've recently stopped responding to their current chemotherapy or their current olaparib or other substrate PARP inhibitor. So those drugs in the previous slide in red. And what that involves, it's not easy for patients. We're targeting a very small population of patients, but we're doing it because we think it's going to be the right treatment and we think it will be effective. So what that involves is getting a patient to hear about the study and going through the process of what we call pre-screening. And what that means is meeting your oncologist, reading some information about what the study pre-screening steps involve, taking the paperwork home, discussing it with family, friends, and loved ones, and considering whether it's the right match for you. Now, the complexity is pre-screening doesn't mean that you're going to get onto this study or that you're going to want to participate necessarily, but it means looking into your cancer biology and your cancer cells to see if potentially this study may be a good match for you. And the challenge is, again, that to find out if this is a good match, we actually need some tissue from the cancer. And we think because these resistance or these challenges in treatment responses over time evolve, and so the tissue we may have had at the time of diagnosis may not reflect what the cancer is doing now. And so we need new tissue. And so how we propose to do that is through a biopsy, using a CT scan to guide a needle in to get some tissue, or potentially draining some fluid from the belly if that's easily accessible. Those samples will then undergo complex testing looking for this fusion and the lack of a reversion, and that time will take about 4 to 6 weeks at the longest to get the results of this study. Now that's a difficult time because we accept that patients may be starting to have a rising CA-125, but we've certainly planned for that and allowed patients to continue and be able to have treatment while they're awaiting the results. When the results come back, we will then discuss the results with the patients, and should they be found to be eligible, we then go through what's called a screening process to see, again, if it's something that patients are interested in doing, again, if they meet all of the safety criteria, and again, if they'd like to participate. Once on the study, all patients will receive the study drug pamiparib, so it's not a randomized study. There's no placebo. It's an active therapy for all comers. We've divided the study into 2 small groups so that we can ensure that we're really learning more about the disease and looking at patients who've started to have disease resistance, most recently on olaparib, or disease resistance most recently on chemotherapy. So we've purposely tried to create space for 2 different subsets of patients so we can see if there's a difference in benefit. I guess the other novel thing about this study is we know this drug, it's been through trials already, but we don't have a lot of information about what it does to patients over time. And so we'll be using some of the most questionnaires, which are questionnaires that patients will be asked to do throughout the study to ask what their current symptoms are from their disease, what current side effects they may be having from treatment. And this is a really important part of the study to see if not only is it a good effective drug, but if it's well tolerated. Another novel part of this study is acknowledging that pre-screening is difficult. We accept that patients have to go through this to be selected for this study because the tests take a few weeks to get the results of. What we also suspect is that it's a terrible time for all of us, and so we want to assess that formally. And we'll be asking patients to take some questionnaires, assessing their levels of distress and anxiety about going through the process. Because as ovarian cancer research develops, I suspect many, many more of our studies will be more specific and more targeted for patients. And so we'll see quite a few studies like this that may be selected for very specific groups of patients. And we need to know what this does. I think we suspect that it's stressful and it's distressing. I know it is for me, waiting for the results to give to a patient. but we need to document this clearly, and we need to see what supports need to be put in place for patients during this difficult time. So there'll also be a few sets of questionnaires for patients undergoing that process so we can better comment on this situation and address the needs that need to be met. So I guess I've spent a bit of time highlighting the PRECISE study, but what I've not talked about, and I think it's an important part of the OASIS initiative and ANZGOG's drive for future research, is the part of this graph here in blue. We suspect we need to screen 200 patients, so request 200 patients to have biopsies to be able to find the 40 patients that we think we need for this study to prove whether or not it's an effective treatment. That means 160 patients will not be suited for this study. But by participating in the pre-screening process, not only will we learning more about anxiety and distress and how we can improve upon things in that process, but patients will also be offered the opportunity to co-consent into another study that many of you may participate in or be aware of, called the Australian Ovarian Cancer study. And that's a very large study with thousands of women around Australia looking at collecting patient data, clinical outcomes, and tissue from patients who've kindly volunteered biopsies or blood samples over time. And so this blue section of the study is really valuable because we'll also be able to learn how patients who couldn't come onto the study respond to other treatments, because there's currently one published review about how patients respond after a PARP inhibitor. And so a lot of what we do at the moment is our best guesstimate, and that often relies on going back to a chemotherapy or thinking of another clinical trial. So there'll be an invaluable amount of research driven from this study, even for the patients who don't participate in actual study drug. So I guess taking you to my final slide, how has this been possible? I hope I look very young. That was the plan today, but I obviously am very young. No, but I'm a more junior medical oncologist, and I'm very invested in research, and ANZGOG has been a fantastic support getting me through to getting the trial where it is today. If you can believe it or not, the idea of the study really came about a year and a half ago, which is a remarkable turnaround time from a concept being drawn up on a whiteboard not too dissimilar to the one over there, to now being able to stand here and say to you that we have ethics approved, we have an agreement, we have funding through ANZGOG, we've got drug from the pharmaceutical company, and we've had a lot of fantastic support to get it that way. So this is another terrible plot that we're actively changing, and I am very hopeful that the next time I get to speak to some of you in this audience, we'll have some exciting results to tell you about from the PRECISE study. I guess I want to thank you for supporting ANZGOG and for being here and attending virtually, because without this passion from you, our research would be meaningless. So I thank you all very much for your attention, and I look forward to answering any questions in a few minutes.
So we're just going to invite Associate Professor Beale to come on stage as well, and we'll ask you for some questions, and both Ali and Phil will be able to answer. We have the mics, girls. Is there any questions? No? None from online? Okay.
I have a question.
You have a question?
That study that you were talking about, that's only for people who have the Braca mutation?
It is. So the question was, is the PRECISE study only for patients with Braca mutations? And that reflects a really important point, that we think that PARP inhibitors can be an effective drug in patients without a Braca mutation. I guess when you have evidence like that, the question is, how do you devise your trial? And what we think, to not lose an important signal in a new drug in a new space, is to try it in the group of patients we think it's most likely going to work. And that's why, again, this is a small study, 40 patients. But if we find signs that it's effective, obviously we want to expand that indication and who can get access to that drug. As I illustrated previously, how PARP inhibitors have moved from after the second line of chemotherapy now to the first line of chemotherapy in patients with Braca mutations, things are changing quickly. And should there be a good signal from this study in a group we hope will be responding, that obviously we would be opening it to, in a larger study, to other patients and potentially other cancer types, because we know that these fusion abnormalities can occur in breast cancer, prostate cancer, a few other cancers. So it has a lot of potential for reaching out to a lot of patients. Great question.
Is there targeted therapy for patients without a Braca mutation?
That's a good question.
Well, I mean, I think that is indeed, currently there's not specifically a targeted therapy for that group, but that is indeed what we are trying to do, especially through that collection of tissue where we are now with a number of programs identifying lots of changes in the cells so that we can identify those and then get the drug that will target that. But that's the sort of link between the new treatments and finding out about the biology of an individual case.
Do you have any idea what the timeline is for the PARP inhibitors to be available to people who have had first-time chemotherapy and then have
Well, it is available now, but only on a compassionate basis. So it is available, but it's a sort of a specific application process rather than just the normal prescription process that we would do through the PBS.
And do you have an idea when it might be available for people that might not get it through the compassionate reason?
Through the PBS?
Yeah.
Well, the PBS takes longer. It's a longer process. It would be in the order of 12 months is the sort of time frame you might think, but it might be accelerated. We never know.
Okay, thank you.
So we're talking about high-grade serous. Are there any thoughts about PARB inhibitors with low-grade?
Well, what we know is that if you, in the studies that have been done, again, all the AOCS that Ali referred to, that when we look in the number of BRCA mutations in those other types is really very small, very rare. There's a few, but they are very rare. So we won't, those other types do not tend to have the BRCA mutation. So currently where the funding is and where the drugs are, that's not available. But would some of those cases be susceptible to the treatment, meaning could they have some susceptibility, again, which Ali was talking about, the other types of abnormalities? The answer is almost certainly yes. But that's still a work, unfortunately, that's a work that's going forward. There's more questions?
There's one down here. What's the state of play at the moment with immunotherapy?
Well, I gave a talk actually at a patient forum actually like this in Brisbane just last year, and we talked about immunotherapy. The moment about immunotherapy, if you just say, here is the immunotherapy maybe you've heard of, in the media and has been used in melanoma and in lung cancer, the answer is that it doesn't work very well. The response rate, like in terms of tumour shrinkage, 8%, only 8. So it's not, in its current form, it's not, we don't think it's the right treatment, not for ovarian cancer. But even since I gave that talk last year, there have been a trial where they did look at giving immunotherapy with some chemotherapy, so like one dose of chemotherapy and some immunotherapy, and the response rates went right up to 30%. And so, okay, maybe there are ways which we can make it work better, but we still don't know that in enough detail, and it's not available still yet to be given to patients. But there is also, in people who are having chemotherapy for the first time after the diagnosis of ovarian cancer, immunotherapy trials are now being done to look at the effectiveness of immunotherapy given with chemotherapy right at the very beginning. And there's a huge amount of effort going into that right now.
What's the blood X thing? Yeah, how are you discovering it at the moment? Mainly from the breast cancer side, the blood X there, and then saying, right, we look at cancer in the ovarian cancer. Do we go from one to the other, or can you just discover it without going that route?
I think the answer is that we learn lessons from each cancer, and because there are some similarities, but there are also quite a lot of differences as well. So there's a lot of cross-fertilisation about understanding the biology and the nature of different cancers like breast cancer, or whether it be bowel cancer or lung cancer, and that then will feed into the information that we have from ovarian cancer. So it's a cross-fertilisation of ideas, but acknowledging that some things work in one cancer but don't work in another.
So mainly if you do come across it, it's an accident for some other procedure and then you find ovarian cancer?
Do you mean in terms of the detection of it?
Yeah.
Sorry, I misinterpreted your question, sorry. Yes, well, the detection of ovarian cancer, you're right, is really very hard because at the moment the symptoms are quite non-specific, and we know that the vast majority of women who are diagnosed have more advanced disease because it is very hard to pick up at its early stage. So it's either, yes, by accident in the early stages, or it's unfortunately with symptoms of more extensive growth in the later. It's certainly advanced at that stage, yeah.
I just have a question about the tissue samples. Is that just happening as a matter of course through surgery, or is that the Innovate trial, or how are the tissues being gathered and tested and analysed, I suppose?
Well, look, I think so. There's two things maybe. I think in Ali's study, the biopsies aren't new biopsies, so they have to be identified in the current state. You know, so if there is a regrowth, then the biopsy would have to be done on that new growth. Innovate is a study which is it's a great initiative run through Anna DeFazio at Westmead, and it's looking at taking the tissue at the time of that initial diagnosis, so like at surgery. So from the surgery, that specimen then will be, with the appropriate consent, will be then taken to that laboratory, and some of the work that Ali has just highlighted would then be done on that tissue, so we have the knowledge of the cells as early as possible, so that we can hopefully be as smart as possible, but saying, well, okay, there is a Braca mutation or there is another mutation, and we can find a way of then being able to target that. Sorry, I was talking.
Is the PARP therapy an ongoing therapy, like maintenance
In the trial?
in the trial?
So I'll answer a question. It is. So
Right.
as long as the patient is responding to the drug, tolerating the drug well, they'll be able to continue the drug. And you know, the only situation that would change would be if the drug came on the PBS and became accessible, or if something extraordinary happened with the study where we had to find a different way to access it very quickly.
Thank you very much.
I feel like I've neglected people here. There was a question.
Okay, you've got time for just one more because we are running behind.
Sorry, I couldn't make it.
I just want clarification about one of your slides that you put up. You had, where you had the pump and you had a table with all the different drugs. The top band said yes, the bottom band said no. Can you explain what does the yes mean, what does the no mean?
So the drugs at the top in red were drugs that we think can be pushed out of this drug pump should your cancer develop this fusion. So we think that if you have this fusion and your cancer stops responding to current treatments, it's likely to be one of those treatments bolded in red. So two of the big treatments in ovarian cancer, carboplatin, gemcitabine, cyclophosphamide, don't seem to be pushed out of that pump if you develop an abnormality. So it may be the case that patients would be on those drugs, and when we biopsy them, may or may not have a fusion. So it's just something for us contextually to think, particularly when we look at those patients who may not go on to the study and assess their response to subsequent therapies.
Thank you.
Thank you very much.